Hi, everybody. My apologies for the bad voice. This is why I'm actually doing the pre-recording. Unfortunately, I've been knocked out with a bad chest infection since last week, so I won't be available in the morning. So that's why I'm pre-recording the um, video for us, just so that you guys can have a look through and see. So today we'll be discussing quite a bit. So I don't want to waste too much of time, and I hope you guys get some benefit from it. So the first thing that I had given you you guys this ECG last week to have a look at, and what we're going to do now is that we're going to analyze it. But what we have is a 26-year-old man with severe weakness and lightheadedness. So very often you may assume that there's a few things that are going on. You look at infection, you'd look at tumor, then you'd look at cardiac, you'd look at respiratory, you'd look at any form of shock, septic, hypovolemic, neurogenic, and then you'd also come to cardiogenic shock, especially if they've got low BPs. And any patient who's experiences, you might think of central nervous system problems with lightheadedness. You may even think of what you call vertigo and things like that. But the weakness itself, as you can see, it's a very non-specific presentation, and so you decide to do an ECG, and this is what you get. So the first thing that will strike you is that is an obvious bradycardia, but we'll get into it now. So as usual, let's just follow our system so that we know what's going on. So if you look at the axis, we've got the lead 1 that is biphasic, and we've got lead AVF, which is positive. So it's actually starting to trend towards a what you call it, a right-sided axis, all right? A normal to right-sided axis. So it's sitting more or less on the boundary of that, but still keeps it within the normal thing. Now let's go through our rhythm so that we know what's going on. So the first thing that we look at is our P waves. Now, one thing that you'll notice is that the P waves are a little bit shallow, all right, but they are still present. And if you look at our PR interval, we look at the peak there, 1, 2, 2.5 to 3. So we're still within normal. Right? So that's our PR interval. Our QRS complexes are narrow. All right, and then our groupings are quite regular. So this is a sinus bradycardia. So how bad? Well, actually, sorry, my apologies. Not a sinus bradycardia. The groupings are not regular. We've got occasional premature ventricular contractions, which is what's happening here. If there's a little P wave in front of those, which may be here, then you could say it's a premature atrial contraction as well. So what's happening is that we have this what looks like an irregular pulse, where we've got 2 normal beats and then a double beat, 2 normal beats and a double beat. Okay, so that's how you would describe. And there's a lot of reasons for what you call it PACs, premature atrial contractions with bigeminy. It's too much to go through in this. We've covered it in a previous talk, and I don't want to bog you all down because there's a few other things that we have to look at. So let's have a look at and like I said, it is a bradycardia. Overall, if you look at it, our heart rate is about 1, 2, 3, 4, 5, 6, 7. So we're hitting about the 50s more or less, which is quite low. If we look at each zone, if you look at the inferior zone, we notice that there's no real ST elevations or depressions. The one thing we do notice is the odd T waves that almost seem to, be taller than your normal PQRS, your QRS complexes. And if we come here to V1 and V2, the one thing we notice is Q waves. So we've actually got Q waves in both of these. There's no little upturn. There's just the straight downturn and the T wave inversion as well. So normally when you have a Q wave in V1, it doesn't mean much. But once you see it in V1 and V2, ischemia has to be considered as well. So in this case, even if the patient doesn't have it, but you do the enzymes just to be sure, especially because when you look at V3, I mean, this looks like a little upturn, but that doesn't. So this could also be a Q wave. Here we notice as well those T waves just being a bit inverted, and then we notice the, what you call it, upturn there from V3, and we start seeing a bit of a peak P wave. But all of that put aside, once we come here, this is where we should get our answer. So what happens here? We've got our QRS complexes, which we can see here. And then we see our tall peak T waves. Now, this should be the first indication that something is going wrong. Once you see these tall peak T waves, these are very indicative of hyperkalemia. And hyperkalemia can lead to a whole lot of dysrhythmias, ischemic changes. It can lead to a lot of cardiac, abnormalities being found on the ECG, simply because it increases contractility and it increases the, what do you call that now? The it increases the action potential threshold, which means that your cell membrane threshold is also increased and gives it a greater chance of depolarizing. Sorry, I had to find my words in the middle of all the medication. So, so you've got these 12 peak T waves. Now, the way that I ask people to always remember it, look at this T wave and ask yourself, would you sit on this? And the answer is no, you wouldn't sit on this T wave because in all honesty, it looks quite painful. It's quite sharp. It looks like it would hurt you. Whereas if you look at, let's say, a more conventional T wave, although it's not conventional per se, but if you look at this, it's more rounded, it's less painful, let's put it that way. So once you have these tall, painful peak T waves with very sharp points, your mind immediately goes to hyperkalemia, and especially with the bradycardia. So you would ask the question, well, if it's causing hyperexcitability, wouldn't we be getting a tachycardia? And that's true. Initially, you would get a tachycardia when the patient first starts exhibiting symptoms. And when the patient first starts developing any sort of hyperkalemia. But as it increases, the ability of the cell membrane to continue at that pace also gets diminished. Now, you must remember, when you are using large amounts of potassium that are unequal with sodium and calcium and chloride, which are all of the other ones necessary to go through the myocardium, they also get diminished and depleted. And the physical ability of the myocardium also decreases, hence the signs of ischemia. And then eventually you start getting a bradycardia. And this bradycardia can eventually develop into what we call a sinusoid pattern. So a sinusoid pattern is almost what we've got here. We've got a deep Q wave and then a tall S wave, but it becomes more conjoined. So actually what happens is you start seeing a wave that goes down like that and then comes up like that and then sort of repeats itself over and over again. So the patient's not quite there, but would get there in a little while. Right? So I hope all of you saw it last week, had a bit of clue as to what's going on. Now, let's just have a look. So as we said, we've got a sinus brady. We said about 50. It came to about 45. The frequent premature atrial complexes, paces, quadrigeminy. It comes on every fourth one, all right? And then peak T wave suggestive of hyperkalemia. So the overall rhythm is regular, irregular. And regular irregularity should suggest one of two possibilities: second degree AV block or regularly occurring PACs. Now, in our case, we saw the regularly occurring PACs. Second degree AV block is ruled out because all of the P waves are conductant, which is what doesn't happen with an AV block. All right. And on the other hand, PACs appear every fourth beat and are followed by a pause in the regular cycle of beats. Now, this is the important one. The peak T waves are noted in the lateral precordial leads as well, diagnostic of hyperkalemia. Hyperkalemia-associated T waves can be distinguished from other causes of large T waves by their narrow base, symmetrical shape, and sharp peaked apex. Other causes of large T waves tend to be more broad-based and more rounded at the apex, as I was showing you. Now, the serum potassium in this patient was 8.3, and although common teaching regarding ECG manifestations of hyperkalemia focuses on peak T waves, widening of the QRS complexes, and ventricular dysrhythmias, hyperkalemia is well known to produce unusual bradycardias, AV blocks, fascicular blocks, bundle branching blocks as well, which is some of the things that we saw over there. So the thing is, we can be a dog that's chasing a car. So in other words, you can go, dogs bark at cars when they run past. And the type of dog you don't want to be is the dog who eventually catches up to the car and bites it or makes the diagnosis, but now is confused as to what to do after that. So the question is, we found that the patient has hyperkalemia. What do we do? So the first thing we're going to discuss now, the management of an acute hyperkalemia in the emergency department. But I just wanted you guys just to see one or two things before that. And we're going to talk about how different things affect the potassium levels and why we use certain things. Right? So this is basically a summary of how calcium, which is probably our first and most important weapon in the treatment of the myocardial hyperexcitability that happens. Well, this is a nice thing to read through because it gives you all of the different, what you call it, receptors like the NaV1.5, isoleucine, glutamine, IQ, and things like that. So these are the ones that actually control the cell membrane and allow for the movement of electrolytes through there. So basically what calcium does is it decreases the the action potential threshold. In a nutshell, that's basically what this is saying, just in pathological language, right? So if you were to become a chemical pathologist, this would be something that you would have to know quite in depth. But for those of us not as brainy, the simple way to explain it is that imagine your action potential or your cell membrane potential is somewhere here. in the middle. When you take potassium or have high potassium, it goes up to there, and calcium basically pulls it down. That's about it. That's all that it's doing, right? And the way that it does is by binding to this, decreasing the excitability and the ability of these channels to open, so that less potassium can move across, resulting in less sodium exchange, chloride exchange as well, and that's what decreases the action potential. Right? So the thing is that why I wanted you just to know that, because the question is, how do you manage hyperkalemia? So the first thing that you do when you note this, right, you want that patient not to go into arrhythmias, and you want to actually start decreasing the potassium thereafter. But the first thing to do is decrease the hyperactivity. Once you decrease the hyperactivity, what you're actually doing is decreasing the chance that your patient will go into an arrhythmia, because the longer those potassium levels stay high, the greater the chances that your patient is just going to get quite bad, either with a tachy, a brady, a fibrillation, things like that. So the first thing that you do when you get what looks like a significant hyperkalemia, because remember, hyperkalemia is very non-specific. It doesn't present with any particular problems per se. It's very non-specific. Your patients are just not feeling well. They maybe, have decreased level of consciousness, as this patient was just feeling weak and lightheaded. So when you can't find another cause, well, in fact, in most of these patients, we should be doing a blood gas just to check initial potassium levels and all of our electrolyte levels and ECG, things like that, because it just shows you how bad this will be. Now, I mean, they haven't given us a full picture of that patient, but considering it's a 26-year-old with hyperkalemia, you'd be looking at renal impairment. So your patient may have other signs of renal impairment like fluid overload, dysuria, polyuria, aduria, oliguria, things like that. So there may be other things that are pointing towards it, but just for the sake of time, maybe they don't give us all of that. So the first thing that you do is you give 10 milliliters of calcium. Now you get calcium gluconate, which is the most common one that we use, and it's normally given IVI over 10 minutes. Right? So what happens is it quite quickly decreases the hyperactivity. Now, the one golden rule of thumb is never bolus electrolytes, be it sodium, potassium, chloride, calcium, magnesium, phosphate, whatever it may be. Don't bolus them. Always give them over a recommended time. So with all of them, they have different times that they should be given in. And calcium is generally given in over about 10, even 20 minutes to give it safely. Right? And we give that calcium regardless of the current calcium levels. All right. Now, this has to do with bindability to the receptors, things like that. So don't worry about your calcium levels. Just give the calcium. It will break down the initial hyperactivity. Now, after that, we do something called a potassium shift. Okay, so a potassium shift is also a combination of calcium gluconate, 10 mg. We normally give 10 units of act-rapid insulin or equivalent, whatever you have, and we give 40 mg of 50% glucose. All right. Now we add all of those three into 200 mg of any crystalloid that we have, and it's given over 30 minutes IVI. Right? So calcium we've already discussed. It's going to decrease the hyperexcitability of the myocardium. And what happens is act-rapid actually causes potassium actually piggybacks on the insulin. Insulin attaches to the myocardial receptors for what you will call it potassium, and then that encourages, that moves into the cell as well. And while doing that, the potassium actually piggybacks on it and starts to become intracellular rather than extracellular, which is causing the problem. And the reason we give the 50% glucose is because we'll also be decreasing what you would call it intravascular glucose level. So we have to give a bit of glucose to try and sorry, we give the glucose just to counteract that. Sorry, that's the word that I'm looking for. Now, if your patient is hyperglycemic already, don't add the glucose. It's no use. It's not going to help. In fact, you're just going to be not doing any harm, but you're just wasting the glucose. You know, if a patient's already got a high glucose level, just give them the act-rapid plus calcium gluconate. And if hypoglycemic, you may want to add even 20 or 40 mg in some cases. But what I would suggest is that keep your patient on a 5% glucose drop in any case, but this may not be enough, especially if you're giving this over 30 minutes. After you've done your potassium shift, remember, after every potassium shift, repeat your potassium levels, because you want to know, are you making any difference, or are you not making any difference? Is there something else that may be causing it? You know, does your patient need a high level of care? Do they need acute dialysis? There's a lot of things that you've got to look at, okay? So what else can we give? We can give AB DEBs, albuterol DEBs. Now, the thing is, albuterol DEBs work very well, but they take about 30 minutes for the full effect, whereas your, what you call it, your potassium shift calcium gluconate, within the first 30 minutes, you already start seeing an effect, right? So that's the third one that we can use. And for a lot of patients with severe hyperkalemia, we actually give this on a continuous basis. So we just keep on giving them AB DEBs until such a time as their potassiums go down. Then we have the use of, we have sodium bicarbonate, but we also have what we call the rule of sevens for sodium bicarbonate. So generally, when we will use sodium bicarbonate in most cases is when our pH is less than 7. Now, sodium bicarbonate affects your acidity and alkalinity. Of course, it's making your pH more alkaline. So it starts bringing you back towards the 7s and greater. And of course, it increases your sodium levels as well. So there's a few things that you have to be careful of. So when your pH is less than 7, you give normally 1 millimole per kilo per hour, all right? So for example, if you had a 50 kilo person, you would give 50 mils of 8.5%, because in the 8.5% solution, 1 millimole is, sorry, it's supposed to be 1 milli equal, sorry, not 1 millimole, but 1 milli equal in 1 mil, all right? So if you had the 4% solution, then every 1 mil is equal to a half, right? So you'd have to give 2 mils, okay? So, but let's just use the 8.5, which is the most commonly used one. So if you had a 50 kilo person, you would give 50 mils of your bicarb over an hour. If you had a 100 kilo person, you give 100 mils, for example, and things like that. The other time that you use sodium bicarbonate is, let's say your pH is relatively normal, but your potassium is above 7. You would also give sodium bicarbonate. So this is a generally accepted practice to use. However, the only time you try and avoid sodium bicarbonate is when you use what you call it, when you have a chronic kidney disease or even acute kidney disease with severe symptomology, patient lacking fluid overload for whatever reason, and a patient who's already hypernatremic, try and avoid sodium bicarbonate. It causes a lot of intravascular shift of fluid. So this can lead to severe pulmonary edema, cerebral shrinkage, and edema. There's a lot of things that can be affected by it. So it has been shown to actually sometimes cause more harm than good. But if you follow this and generally give it over an hour, you shouldn't have too many issues. And there are times when we've used it, even in these situations, at a lower dose, just to try and ease up certain things, you know. So basically what happens is that sodium bicarbonate works via two methods. The increase in sodium encourages the intracellular and extracellular movement of the what you call it, the potassium, and it also increases excretion through alkalinization of the urine and things like that. And then Lasix or any non-potassium sparing diuretic can be used. Well, Lasix is the most common, all right, furosemide, because it increases potassium excretion. But just using, especially with severe kidney disease, may not work too well. Otherwise, it takes quite some time to actually show its effect, as the sodium bicarbonate, all right? So this is just an algorithm that you can remember. So basically, you give your calcium, then you do a potassium shift, then you give NIBs, then you look as to whether you need sodium bicarbonate, and then you add diuretics. And we've placed it from fastest acting to slowest acting. So this is just a nice little clipping to keep for yourself, and even the last two slides if you want as well. So just remember this, and you'll never go wrong with potassium. So there's no such thing as shifting potassium too quickly when it's high. There is such a thing as shifting it too quickly when it's low. But shifting it when it's high can be done generally as quickly as possible, because you want to get your patient to a normal potassium. And of course, you don't want to overcompensate and make them hypokalemic. So you've always got to consider that. But most patients who are symptomatic would take over 24 hours to actually get back to normal potassium, although it does sometimes happen quicker. There's something else to remember about hyperkalemia, that is your pH. So when your patient is acidotic, all right, so when your pH is 7.35, your potassium levels are actually higher than what's shown, like on a blood gas reading. The reason for this is that acidosis in general, in order to achieve a pH balance, actually forces your anion potassium out of the intracellular space into the extracellular space. So what happens is that what you are picking up in your blood gas, or whether it be a venous blood gas or arterial blood gas, is actually a little bit lower than what you may actually have on the patient. So, and the worse the acidosis is, the worse the disparity. So in other words, a patient who has a pH of 7.3 and a potassium of 5, that potassium is not much higher than 5. But if you have a patient with a pH of 6.9 and a potassium of 5, the potassium is actually much higher than what's being shown. So the greater the pH drop, the greater the disparity between your actual potassium and your measured potassium that you can see on that. And it's the complete opposite for a patient who's alkaline alkalotic. So when a patient goes above 7.45, your potassium levels are lower than shown. So if a patient has now has a potassium of 5 with a pH of 7.5, the potassium is just slightly lower than 5. If a patient has a pH of 7.6, for example, 7.65, which is extremely high, then your potassium levels are much lower than 5, right? So that's basically how it works. Now, what I would suggest is everybody should have access to an online potassium calculator. So these are quite easy. They work out the true potassium within like a second. This is the most common one that's used, skybet.com. And the only thing that you got to look at over there is which unit it's giving, because potassium is measured in milliequals and millimoles. So you just have to look at what your readout is telling you, and then you just got to change that. So I'll put this up on the group as well so that you guys can download it, bookmark it, and then you know you've got it available. So I hope that gives you guys an idea of how we manage potassium and how we look at everything. That's just a little joke just to finish up. If there's any questions, you're more than welcome to message me. I just want to thank Dr. Ricardo from Dan Hauser. Actually guessed it quite well. Well, I wouldn't say guessed. I mean, he knew the answer and he had messaged me on the day when we had actually posted the initial ECG. So well done to him. He's been with us from the start, and it just shows how far he's come as well. And I've seen his work over the last few weeks. And if you guys have any success stories as well, please send it through to us. I've actually got to post Dr. Ricardo's ICD patient as well. But listen, if you guys have any interesting cases, anything that you want us to look at, please post it on the group. And hopefully I'll try and post it for you guys as well. So I hope you'll enjoy that. It was just a little dive into hyperkalemia. Hyperkalemia is a very intense subject. What we've given here is just the top 10% of the iceberg, if I can put it that way. You can go extremely deep with hyperkalemia, but the truth is that we don't need to go that deep when we work in the emergency department. We can for our own interest's sake. And to be dead honest, having read on the subject now for quite a few years, most of it is not really applicable to what we do in an emergency setting. But should you become a physician, nephrologist, ICU intensivist, things like that, you need to know it in much greater depth. But generally, for most of you guys, what I've taught you here will keep you going in your career until such a point that you actually reach one of those stages. And you never need to know much more than that, and you'll be able to cover a hyperkalemic patient completely. All right. So I hope you guys enjoyed it. And yeah, we'll post the SkyMed calculator on the group as well. And yeah, for those of you who are waiting for CPD points, I'll also post it on the group, but there's currently only 5 people at the HPCSA who are actually handling all the CPD submissions for the entire country, because I wanted to know, they sent us the first batch very quickly, and since then we haven't been receiving many. So when I did message them, they told me this is the issue. There's just 5 of them in an office who are handling everything, and even though it's relatively automated, there's thousands that come in a day. It looks like, well, I not say thousands might be an exaggeration, but there's hundreds that come in a day, and they've got to go through all of them. So it does take a bit of time, but hopefully the CPD will start showing up soon. All right, keep well. Bye.